Hi, everyone. Welcome to Optimizing Whole Person Care, a successful integrated care model. On behalf of Open Minds, we want to thank NextGen Healthcare very much for sponsoring this and for adding to our scope of knowledge about this very important topic. We all know that integrated care is what's happening now and what is likely to be happening in the future, so we're very excited to present this webinar to you. Just a couple of housekeeping items. Everyone who is an attendee is on mute and in listening mode, but we do have a chat box and a question box, and we encourage you to put any questions that you want into that. We will be posting the slides on Integrated Care Online and have them available to people who've attended the webinar. If you have any technical problems or you need any support, just put something into the chat box and we'll make sure that our staff is looking at it. With those kind of administrative tasks out of the way, let's go ahead and introduce Graham Brown, who is representing NextGen Healthcare, and will talk to us a little bit about the future and the past of integrated care.
Indeed, thanks, Sharon. Good afternoon, everybody. I'm Graham Brown. I'm, as noted on the slide here, Senior Vice President with NextGen Healthcare, and I'm one of the NextGen advisors, one of the groups that works with our clients on a regular basis on some of their operational and strategic issues. Pleased to be with you today to discuss innovation in integrated care. And from my perspective, I think it's always helpful to provide a bit of a background, context, and history. When we think about where we came from, it often helps us understand a clearer path of where we want to go and what some of the challenges and operational and structural issues there are that really have informed the state of integrated care today. My recently retired colleague, Dr. Betty Rabinowitz, authored a great piece on this topic a couple of years ago, which I'm going to use as a reference to cover some of the history here. Up until about 40 years ago, there was very little focus on integrating behavioral, mental, and physical healthcare needs. Indeed, up to that point, our approach to assessing care needs, our understanding of the interaction between mental and physical health, were not only separated, but the separation was systematically ingrained in our healthcare delivery model. So how do we get to this place? How did this separation of behavioral, mental health care and physical care come to be the norm? It's a little bit of a history element here. Back in medieval times, it was believed that if you were to ascend to heaven, your body had to be maintained intact. And what that really meant was that leading discovery in medical areas around autopsies or dissection and actually looking at the body and understanding its systems and how it worked was considered taboo. As the church continued to kind of gain collective power through those mid-centuries, the domains of the human mind and behavior became enshrined in dogma. And as practice, really that whole element of the human mind and behaviors associated with it really belonged to the church in their eyes. And that became very much how the separation initiated. The evolving fields of scientific investigation weren't exploring the entire physical body. They were leaving the mind to the church, and that was accepted dogma. Really in the era of René Descartes, the whole concept of Cartesian duality came about. And this postulated that the mind and the body were actually two totally separate, distinct entities, and that events in the body were separate from events that happen in the mind. So if one experienced any kind of physical trauma, the mind was dissociated with that in terms of your body's reaction. The widespread adoption of this approach solidified that further separation of mind and body in the evolving science of medicine. So these factors really established the primacy of that biomedical model right up until the 20th century, through to the introduction of something called psychosomatic theory. And psychosomatic theories were formulated to try and bridge the divide between mind and body by exploring the relationships among physical, psychological, and social factors in the causation, prognosis, and treatment of illness. 1977, getting close to recent times, Georg Engel proposed the Biopsychosocial Model, which recognized the nuance and multifactorial connections and causality in terms of disease, recognizing that in any and every disease state, there's an interplay among the biological, the psychological, and social factors in terms of how disease develops and how we recognize its implications. This model and its acceptance into medicine's mainstream really provided the theoretical underpinnings of modern day integrated care. Since the 70s, a number of factors have shifted in terms of how we think about behavioral health and mental health care, and increasingly bringing these needs into the mainstream of medical practice, medical education, which is important in terms of how we train our providers, and then community care. At the end of the 20th century, last 30 years or so, deinstitutionalization was a stated government policy. And not just in the United States, but really globally, this was happening. Throughout that era, we were moving individuals out of large institutional facility settings and into care settings closer to home, where people live so that they could be with their family and really grow up in a more independent and community-based environment. But with deinstitutionalization brought enormous financial pressures in terms of the cost of care shifting out of large facilities into smaller community settings that had different staffing needs and staffing ratios. And even today, our workforce is struggling to catch up with the volume of care required to serve individuals effectively at the community level. At the turn of the century, the Institute of Medicine's Committee on Quality of Health Care in America issued the seminal publication called Crossing the Quality Chasm, a new health system for the 21st century. And the report found quality problems occur typically not because of a failure of goodwill or knowledge or effort, or the resources devoted to healthcare, but because of fundamental shortcomings in how care is organized. As a result, the nation's current healthcare system often lacks the environment, the processes, and the capabilities needed to ensure that services are safe, effective, and patient-centered, let alone being provided in a timely, efficient, and equitable manner. So the report came up with a variety of recommendations in terms of performance expectations, setting new guideline rules for how patient and clinician relationships were to be established and monitored. And they really promoted a variety of key steps around putting forward evidence-based practice and strengthening clinical information systems to allow research to be undertaken in this area. So if we fast forward a little bit from the turn of the century to 2010, we have the passage in the United States of the Affordable Care Act. And while the key premise of the act and its purpose in many ways was to dramatically increase access to healthcare insurance coverage, remembering that in 2009, there were over 46 million persons in the United States of all ages, over 15.4% of the population then, that were uninsured. But the Act also established, through its policy focus, the Centers for Medicare and Medicaid Innovation. And that group was really instrumental in testing a whole variety of different innovative payment and care delivery models for federally funded programs. So as a result of that, accountable health communities, accountable care organizations, state-based health innovation awards, and countless other initiatives followed to spur innovation, fund new models of integrated care, and to track outcomes. The goal of much of the funded companion research and quality measurement programs was to figure out what of these models worked best, what approaches to care result in better outcomes, and how can we more effectively finance integrated care to make these provider organizations financially sustainable and forward-thinking in their growth and program development. And of course, innovation in this area is just as important today. People with serious mental illness and substance use disorders continue to have high mortality rates, poorer health outcomes, and face significant barriers to care. They experience a higher incidence and prevalence of preventable disease, including cardiovascular and respiratory diseases, diabetes, and HIV. And co-occurring disorders are associated with higher levels of both emergency department use and unmet treatment needs. So that's some of the research that's been funded as a result of some of the IOM initiatives and CMMI's initiatives that really show some of the challenges facing integrated care as it stands in our delivery system today. Recently, of course, the COVID pandemic has highlighted the prevalence and helped reduce the stigma associated with experiencing mental health issues, but it's also shone a bright light on how challenged we are to meet this need with the social service and health delivery care system we have today. And yet at the same time, there's enormous effort underway to recognize the need for breaking down this historic separation and putting up models of integrated care to the forefront. So let's segue then to the topic at hand today, a little bit of the state of integrated care as we introduce and welcome Mary Jo Whitfield. Mary Jo is the Vice President of Integrated Care at Jewish Family and Children's Services in Arizona. And Jewish Family and Children's Services has been a client of NextGen and its precursor systems that we acquired for a number of years. Mary Jo, nice to see you. Thanks for joining us.
Thank you. Nice to be here.
Sharon's back on the line here as well. So Mary Jo, maybe you could just begin by introducing yourself a little bit and tell us about Jewish Family and Children's Services.
I'm Mary Jo Whitfield. I am the Vice President of Integrated Health here at Jewish Family and Children's Services in Maricopa County, Arizona. And we actually have been in Maricopa County since 1935. So we're one of the oldest sort of social service behavioral health entities in the state of Arizona. And we did not start out providing behavioral health care. We actually started out as a social service agency and have evolved through the years to provide, we actually have 3 divisions. So we serve older adults in our Jewish community, and we also have a very large child welfare, home visiting, family preservation type services, is in addition to domestic violence services and early prevention services that is covered in one of our other divisions. And then our largest division is our division which covers all of our integrated health care. We started providing behavioral health services in 1980 and have over the years sort of evolved into adopting integrated care. Our Medicaid agency, which is the Arizona Healthcare Cost Containment System, began working on preparing the system to begin to provide integrated care about 8-9 years ago. So for us to get ready for that, we wrote a grant and hired our first integrated health navigators prior to us actually acquiring the licenses to establish integrated care, and began to screen everybody for chronic health conditions, everybody that came into our clinic, because we're a really big behavioral health clinic. We have 5 locations in Maricopa County, which by the way is bigger than Rhode Island. It's a big area. We have our outpatient clinics located in sort of the 4 corners of the county. Each clinic has a catchment area. We began with a clinic, our Michael R. Zent clinic, which is located in an area called Maryvale, which is actually caters to the zip codes that probably have the highest rates of Medicaid eligible members, children involved with Department of Child Safety, as well as a huge number of people who have come here as refugees from other parts of the world. Arizona is the 5th largest refugee resettlement state in the country. So in addition to all of the other things we do, we also have a large refugee population that we serve. So
I was going to just ask if were there specific things that you were seeing in your clinical population that led you and the leadership to think about integrated care as a viable next step?
We had a lot of very healthy encouragement from our state Medicaid agency. Tom Betlak was our director at the time. He was a firm believer in whole person care and was one of the, one of the state Medicaid directors who really sort of pushed this on the federal level. And so we had a lot of preparation for it. Because we have such big clinics. It sort of seemed natural, particularly in our where we're located, in sort of the areas we're located in Maricopa County. And then when we started screening everybody for chronic health conditions, it was like, oh, wow, you know, like 75% of our members had at least one chronic health condition. So it just sort of made sense that we would sort of go down that path. One of the things about Arizona that people probably need to understand is that we have never not had managed care in Arizona. We didn't adopt Medicaid until the 80s, and we were the last state in the union, I think, that did that. So we've always had managed care, and as a result of that, I think, you know, we started with on the medical side of the house in Arizona, and then in 1990 we added behavioral health and substance use disorder treatment to that benefit package. So, you know, we've been doing this a long time. And from that standpoint, I think in some ways it made it easier because of the way we're contracted. And as you all know, and any of you who are going to try to do this or are doing this know that contracting is a really difficult area in terms of healthcare integration, because it sort of has always existed in silos and side by side. So getting your funding agencies to integrate their contracts is an ongoing challenge. Let me just say that.
Yeah, and I think that's an excellent point. My guess is that people who are practicing in states other than Arizona, because you do have an infrastructure that's been built very carefully over time, excellent crisis programs, you know, all kinds of kind of interdependent infrastructures. In lots of other states, folks who are, you know, customers of Open Minds are reporting that it's difficult to even get the contracting to be discussed, you know, kind of who's primary and how do you bill it and what's, you know, what's reportable and things like that. So,
well, what we did is after we had our integrated health navigators for about a year, and we had pretty much screened everybody who was enrolled with us and realized that we have a lot of opportunity here. The gentleman who was our CEO at the time, who was also somebody who was very instrumental in building the behavioral health system in Arizona. So we were fortunate to work with him, and he had a lot of vision around this sort of thing and was not afraid to try something new. So we developed a strategic plan like everybody does, and we did a lot of research. We literally did research. In fact, we complained bitterly, all of us on the executive team, about having to write research papers around why we needed to do integrated care. But it was really, it was very helpful in helping to start to solidify what we were looking for, what we wanted it to be. We looked at a number of different models, because even today, when you say integrated care, there's a lot of different definitions of that. What we did was we chose to embed our primary care services in our existing clinics, which was, I think we might have been the only agency in Arizona at the time that did it that way. A lot of our sort of sister agencies did other things. They did co-locations. They made their behavioral health services available in primary care clinics. And then you always have the FQHCs, the federally qualified health centers, that have been doing a level of integrated care for a long time. However, we have a number of we developed a number of affiliations with FQHC, one of the biggest ones actually here in Maricopa County, which is our safety net. It's defined as our safety net FQHC's hospital system. And so we have a partnership with them that is longstanding. It was developed early on because we're the primary provider of behavioral health services to their refugee populations, and they have a refugee clinic. So it's sort of natural for us to partner up. And the agency that provides all of their medical personnel also, when we initially started this, provided our medical personnel. So it was just sort of a natural fit. The good news is that in the midst of all of this, when we decided to start doing it, we also realized and recognized that Access, our Medicaid agency, was going to they RFP'd our whole system. So we had to quick get our clinics, we start to license our clinics as integrated clinics to get our primary care physician providers on board and then start to build that infrastructure. I am not going to lie to you. It was a really heavy lift. And this is not something that happens in 6 months. We've been doing it for 6 years. We just integrated our last clinic last year, and it's a very heavy lift. And our agency, because we've been in operation for a really long time, was very well established. We were fortunate in that we had a lot of people who had been working with us for a long time on the behavioral health side. And so, as all of you know, when you're asking people to change, we're good at asking our clients to change. We're really bad at doing it ourselves. So that was really that was a fascinating challenge. But I have to tell you, what you have to do is you have to give people information. You have to meet with your staff. You have to over communicate, and I mean over communicate. If you've told it to them 2 or 3 times, you need to tell them another 2 or 3 times. You need to ask for feedback. You need to be willing to listen to your line about, why are you nervous about this? What is it about it that's making you anxious? Because those things are important. And if you can't get them on board, then you have to have some pretty hard conversations with people about, maybe this isn't going to be a good fit. Not to be like a Debbie Downer or anything, but those are all real things that people have to deal with. And you have to plan and plan and plan. You have to have a work plan. You have to meet regularly. You have to like redo your work plan when you realize that what everyone thought was a brilliant idea is terrible and it's not working. And then you have to, you know, turn in a different direction. And you have to do this with sometimes it felt like 100 of my closest friends. I mean, there are a lot of people involved in these kinds of projects. And in the midst of this, we realized that if we ever wanted to get a claim paid, we had to upgrade our system, our EHR. So we actually had NextGen for many years. We actually helped develop the behavioral health content for NextGen. And then, but we adopted NextGen 2.0 in the midst of all of that, which I'm surprised my whole staff didn't quit. But it was challenging. But it was the right thing to do because we were integrating care. So we had to have a electronic health record that would not only accommodate our family practice primary care, but also all of our behavioral health and substance use disorder treatment properties. So it was 2 years of, maybe 2.5 years of,
So
it was exciting.
I want to talk a little bit more about your information integration journey, but we do have a question from the audience. Someone asked how your integrated care model is different than a typical group practice model like Kaiser, you know, where they have co-located services.
Our contract, because we're licensed as an integrated clinic, we actually employ the primary care. We employ the physicians, the nurse practitioners, all the providers. So we didn't start out that way. We started out as a partnership, and then we were able to determine within the first 18 months that our contractors couldn't figure out that model. So we went to a vendor agreement with our family nurse practitioners and our medical practitioners. That actually was much easier for our health plans to they recognized that. They were able to sort of develop the contracts around that. So we did it for purely a practical reason. You know, in fact, most of the decisions we've made have been either because it's clinically the most appropriate thing to do and or for a practical reason. It's really hard to get really sort of esoteric around this because it's pretty real and it's really expensive if you make a really bad mistake in terms of that. We were fortunate in that, and also to here in Arizona, because our system is primarily Medicaid funded, it is, we do what our contractor asks us to do. So some of the decision making really was more around, for us, the practicalities of the situation made much more sense for us to not do co-location, because it was very hard for our licensing bodies and our major health plans to figure that out, but to go more towards the model where we started with a vendor agreement and then moved to employing them ourselves. Does that make sense?
It makes perfect sense, especially around the contracting issues.
Right.
Because health plans are not necessarily the most innovative in terms of thinking through contract models when they don't quite understand the service delivery model.
Well, change is hard for everybody. So, I mean, it's not just at the end, the sort of the people that are providing the services. It's hard all the way up and down the line.
Yeah.
Yeah.
Yeah, I was just going to add on to something you were just asking about, Sharon. So it sounds like the state's issuing of the RFP kind of created the impetus for you guys to really formalize what your primary care approach was going to be. As you look back on that, it sounds like you met the needs of the state in terms of being a provider to this population. Would you have come at it the same way if you were today to initiate an integrated model of care? And we're starting de novo, would you stand it up in the same way? Would you come at it differently? Would you begin in one service area, move to another? Would you start with the two hand in hand?
No, I would have done it fairly similarly. I think one of the things we would have done differently is we would have contracted the primary care piece differently, in that we would have started with a vendor agreement and then moved to an employment model, not starting with a partnership. Because even though on sort of conceptually it was a great idea, in reality it was nobody could figure it out. And so we lost some time in terms of being able to stand it up as quickly as we wanted to, and be able to serve the population, because when your primary contractors can't figure out how to pay you, that also impacts your ability to get everybody credentialed and privileged and paneled and, all of that. So I would do it different. I would not do that again. And I would have upgraded my EHR much sooner. I actually probably would have done that before I tried to integrate, not during.
Could you talk to us a little bit about that? Because I do think that one of the questions folks have is around what type of technology, what type of EHR, what type of interoperability do you need to be successful doing this? And I know that one of the points of resistance that people have experienced is physical health physicians not quite understanding what behavioral health clinicians do, and vice versa. And so can you talk a little bit about the EHR setup and why you feel like it's critical to your success?
Well, ours, and we're very biased because we've had NextGen for a really, really long time. And we have never been unhappy with it. It's not perfect. No EHR is perfect, but it has always met our needs, and we have always found it to be pretty flexible. And then when we were able to adopt the latest version, or one of the latest versions, I think we beta tested it, which was also an interesting experience. But it was good for us because it allowed us to work really closely with NextGen in developing the sort of the programming that we needed in order to be successful in doing this. So, integrated, if you're going to really integrate, that means you need to have the same record. All your providers need to have access and be able to see. You have to have all the workflows and protocols in place so that your client population understands that this is an integrated model, and where, if it's been identified that you would benefit and you're willing to participate on both sides of the house in getting all of your needs met in one place, everyone's going to, have permission to look at your record when it is clinically appropriate. So those are the kinds of things that, because we were able to get sort of the latest and greatest version of our EHR, it made it much easier to do that. It also, we have some genius SQL coders that work for us. So we're also able to get like reporting out that has given us a huge advantage from a business standpoint with our contractors. I trust my data much more than I do most of my contractors. I guess I shouldn't say that out loud, but it's true.
But that's an interesting point, because I do think that, you know, it's the old model of kind of garbage in, garbage out, getting staff to really truly understand what should be coded and why and how is a huge problem in terms of developing those kind of actionable reports.
Right. And we, you know, around that time when we started to move towards integrated care, we also created a business intelligence section, and as well as our IT and our QM compliance. So all three of those entities have been there. I think I don't know if we would have been able to do this without them. That infrastructure was very helpful in terms of bringing staff along, providing the training that was necessary, having all of the programming in place so that people could easily code and bill, or, you know, and document and generate the bill, and then, you know, submit the claim, because it all just lines up. So those things are necessary if you're going to be successful with this, in my opinion. Yeah,
absolutely.
Because I think our claims come through on an average between 96 and 98% clean the first time.
Wow,
so
that's really impressive. Someone asked if you have an integrated consent to treatment form.
Yes.
And your client rights, I'm assuming, is also integrated.
Everything is integrated. That's one of the things I wanted to mention, is that when you do this, be prepared. You have to change your job descriptions, your policies and procedures. All of your paperwork has to change in order to reflect this model.
And that's really fascinating, because I think that's one of those things that people wouldn't necessarily know. But since you all have been doing this, that's a lesson learned that I'm sure is helpful for many. Do you input data from external sources like Health Information Exchange, or do you send data out to a Health Information Exchange?
Feeds with our Health Information Exchange. So, for instance, when people who are enrolled with us go to the hospital, we get a notice, and so we download that every day. We get it in real time, pretty much. So, you know, we're able to identify who we have, who's in the hospital, who's in the ED. Our HIE just finished piloting the 42 CFR Part 2. So we're able to get that also for the entities that are participating in that. That's not as universal as the medical stuff. But the medical information actually we've found it to be really helpful because, again, we were primarily a mental health agency. And so if you were enrolled with us, you were more than likely getting treatment for that. And so if you were going to the hospital because you were having an appendicitis attack, it was something we still wanted to know. We used the information we got to make sure that we stayed in contact. We did the follow-up. We provided all of the transitions and coordination of care for our members, because we do it both on the medical side and on the behavioral health side.
Yeah, well, I wanted to, again, build on something you had asked, Sharon, because you talked a little bit about the importance of those integrated systems. And Mary Jo, you spoke about the need to update your policies and procedures, your job descriptions, those things. Could you speak a little bit about the collaboration between the two sides of the house, as you refer to it, and whether it's case studies, grand rounds, working collaboratively directly with clients together? How do the behavioral health and the physical care teams really interoperate with each other?
We have care coordination, a group of people that provide care coordination. So what we've done is done stratification on our population and identified those at highest risk, high cost, high need. And we do care coordination on those folks, and we do regular meetings around where all interdisciplinary meetings. So anybody who's touching that particular member is invited to come and talk and process what's going on. Is what we're doing working? If it's not working, what do we need to be doing differently? Are they going to a specialist for endocrinology, for instance, because their thyroid is out of whack? Do we have that information? Can we get it if we don't have it? So everything is, you schedule it, and then you invite people, and then you help them learn to communicate with each other. And actually, after the first 2 years, I mean, most people are pretty okay with it, on board with it. People who were really not okay with it didn't stay with us. They quit.
We have another question from the audience about the process that you went through to reconcile different regulations, like reporting requirements, restricted by 42.
Oh, we're still doing that. That's a lifelong endeavor, I'm pretty convinced. But I have to tell you, I was actually one of the first people, because I sat on a board of directors for another organization that was doing sort of a different form of integration. They were doing a co-location. And so I went to the first licensure visit because I was, well, just because of the position I was in on the board with the CEO. So the people from medical licensure and the people from behavioral health licensure, because they were split at the time, both showed up at the same time. I thought we were going to have to mediate because they weren't on the same page either. Now, since then, Arizona has done the work, and now they're the Office of Medical Licensure, and they all lived happily ever after. They're all in the same division, and we had to rewrite all of our licensure rules. But it was challenging the first several years because, it was like our Medicaid agency had made the decision that everyone was going to integrate, but all of the other agencies that touch these processes needed to catch up. So it was challenging. So
Yeah.
it's not just your Medicaid agency. It has to be anybody, any other group of people in your state government who are going to be touching your business have to be on the same page.
Yeah, that's a really important point.
Mm-hmm. It was,
Talk a little bit, Mary Jo, about your collaboration with Banner Health, with Honor Health, and other hospitals and health systems within Maricopa County, and how you manage difficult patients or complex patients, or handle those transitions of care from the inpatient environment back into the ambulatory world.
we have a care coordination team. We've had it for 10 years. So even before we had integrated health, we had care coordination team that had established relationships with the different hospitals and went in to help do discharge planning and transitions of care. So we just maintained that and built on it when we started doing this. We added tasks in terms of being able to do discharge planning and follow-up for medical reasons for hospitalization. That was really the major change. It's interesting because it's kind of I don't know about other states, but in Arizona, Banner's huge. I mean, I think they're the biggest hospital system we have. And there is a sort of a phenomenon right now in the Medicaid health plans in that care coordinations is very popular as a vehicle for getting work done. So there are a lot of people interested in coordinating care with the direct service providers, which is sometimes challenging, but because ours is really well established, we've kind of like focused everybody's efforts on sort of the parts of our organization that do that work, particularly, which is really important, particularly now because we have a workforce shortage in Arizona and everywhere, I think. So, you want your therapist, for instance, to be providing therapy, not being on the phone with care coordination from a health plan. Yeah. So, but again, we have a lot of infrastructure that a lot of agencies don't have. which we've just sort of developed over the years to, get ready for this.
Is there a patient population that your integrated care team has the most struggles with? As an example, I was doing some work with a group of primary care providers who really were very anxious about providing services to people who were on atypical antipsychotics. But we know that people on atypical antipsychotics also do need a whole bunch of lifestyle management things because of the increased risk for weight gain, which leads to diabetes. Was there any population like that your staff were particularly anxious about, or where the educational need was greater?
Well, when we started to integrate care, we also added teams that worked with persons with serious mental illness. And surprisingly, the resistance to that came not from the medical side of the house, but from my behavioral health side of the house, because we are, historically, we've been a really big agency in terms of serving children and families. So when you start to add the population of people who are living with a very serious mental illness, there's a lot of mythology that comes with that. We don't have any a sort of community treatment team, so we're not actually treating anybody who's like at that very high end of severity. We work with people who are sort of in that midline category, or people who have learned to manage their illness and they have to have the ongoing psychiatric care. So, and one of the reasons we chose to not include ACT is because we do serve a lot of children and families, and because that being said, we serve a lot of children who have very serious ongoing psychiatric needs. And so having our own teams that serve that population allows us to keep a lot of those children. And so that transition is much better. We don't lose them. They don't end up under the bridge someplace. We don't have to, try to find them in 5 years, and by that time they're a train wreck. So that actually made sense for us. We don't have it in every clinic. We only have it in 2 of our clinics, but it allows us not only to serve the identified patient, but then if there are any other people in the family, or if the person with serious mental illness has children, we can serve their entire family. So we can not only provide for their behavioral health needs, we can also provide for their primary care needs if they so desire. Because people still have a choice. I mean, I think there was this assumption at our Medicaid state agency level that if we did this, then everybody would want to get all their services in one place. No, they don't. It's America. They have a choice. And there's still a lot of stigma attached to having mental health issues. So, not everybody wants all their stuff in one place. And in our, because we do so much work with child welfare and with Department of Child Safety, their system actually had an open panel for the medical side. So all their foster parents, all of their group homes, all of their infrastructure was used to being able to go anywhere they wanted to. So that idea that they were going to have to just go one place was difficult. The system has since evolved to start to address that issue. And so we're seeing more participation in that arena. But it's a process. It's going to be 10 years at least.
Yeah. And it sounds like it's one that requires daily diligence. It's not like, we wrote this plan and then we're going to come back months later and look at it.
You never get to rest on your laurels because you're never done.
We have another question. Someone's asking, what do you see as your top 5 challenges in integration and workforce buy-in? Any recommendations?
I think fear of the unknown, always the fear of the unknown, and the fear of, on the mental health side of the house, that medicine sees this part of medicine, because it is part of medicine, as witchcraft. And that belief system is hard to break. I don't think I've seen a big change probably in the last 5, 6 years that we've been doing this, in that we're starting to see practitioners, family practitioners and other medical practitioners who are starting to see a huge value in what our part of the puzzle brings to the table in terms of being able to help people change their behavior for the better, and teaching people that they are able to learn to manage their illness, whether it's a mental health issue or it's diabetes or it's hypertension. They're not different. They're public health issues. You know, in our public sector, we serve the people that nobody else wants to serve. So they deserve the best care just like everybody else does. So that's a huge opportunity, and you get to see things that you may not be able to see if you're just sort of confining yourself to the folks who are well behaved and not likely to be talking to an imaginary friend while they're waiting to see the provider. But you know.
So the way that you handled that was really through training and education?
Yeah, you have to give people lots and lots of information, and then you have to sort of hold their hand through the process. Because every time you're successful in treating somebody or getting, you know, engaging someone, then that's a win. You know, and you have to be able to process all of that. So if you don't like to process, you can't really do this well. I have to admit, personally, I hate to process anything, but it forced me to practice everything I learned when I went and got my master's degree.
There you go. But it does seem as if that open communication really is your kind of #1 recommendation, because it does feel, I mean, there's even stigma around saying to people, well, you have diabetes because you're not managing your lifestyle well. And so there's that sense that you're kind of blaming somebody for their illness because their behaviors may have something to do with, you know, either the severity or the index.
Right.
And so it does feel like it's really a communication challenge.
Well, social determinants of health are a huge, I mean, these are things that anybody who's been working in the public mental health system knows. I mean, if you're working in a Medicaid system, you're not dealing with people who are even the working poor. You're dealing with people who are pretty much at the bottom of the barrel economically. They have food insecurity, they have unreliable transportation, they do not have good housing stability. So if you're unable to take care of people's basic needs, mental health treatment is a luxury. Period. It just is. If you have to choose between taking your medicine for hypertension or eating or feeding your children, what are you going to do? So the advent of CMS and SAMHSA starting to say to all of us who are out here practicing, you guys need to pay attention to this. This is something I think that behavioral health probably always knew, but not so much maybe on the other side of the house. This is a huge deal, and I think it's a game changer. And then with the pandemic, we also were able to identify we have a huge digital divide in this country. So I think that out of horrible things, some good things are coming in terms of helping to improve care for people just overall.
Yeah, that's really critical. Another question is whether you've seen improved physical health outcomes
Yes.
through this integrated work, and is that something that health plans are interested in, you know,
yeah,
like incentivizing
they definitely are. We're all still fussing back and forth with what are we measuring. I think, you know, CMS is going to take that out of people's hands to a certain extent, because they're starting to look at the NCQA standards and wanting to sort of impose that across the country, which is not necessarily a bad thing. You know, in Arizona, I think we have 7 major health plans, and then they have like multitudes of sort of divisions underneath that. And so standardizing all that reporting and all that all the metrics around that will be helpful to the system and will actually be a big cost saver, because when you have to measure multiple things in slightly different ways, it drives up your indirect cost of care. So again, it'll be a change and it'll probably be painful, but at the end of the day, I think it'll be better.
Yeah.
Yeah.
Couple more questions. Did you was it picking an assessment? Was that a simple thing, or did that also have a bunch of iterations in terms of, you said you kind of started out by assessing people's physical health status and found 70,
Our major
75%.
contractor at the time actually developed a health screening assessment, and so we just used that. And you know, it's pretty basic. You're really looking to identify the major chronic health conditions that people might have, and then all of our mental health and substance use disorder assessments we had already been developed over time. So again, we're a Medicaid system, so our Medicaid state agency pretty much, and our licensure body dictates what elements have to be in the assessments. So it sort of takes all the guesswork out of it. And then we use the PHQ 2 and 9.
9 or 2, yeah.
Yeah. So, you know, and then we have a number of risk assessments that we use to identify suicidality, that sort of thing. And these are all things that have been developed over time. They were not something that we had to develop like right at the same time we were doing healthcare integration. Thank the
So it
Lord.
does sound as if one of your major takeaways, or at least one of the major takeaways I'm hearing, is this is a consistent and constant process. This is not a one and done. I built a model and now it's
Oh no, and it takes everybody. So we would not be where we are today without our QM compliance division or our business intelligence or our IT. So in addition to our chief medical officer and all of our clinical staff who have ongoing input into this process.
Were those infrastructure staff in your business intelligence and QM areas difficult to identify, difficult to recruit or train? Were they folks you had and they moved into new roles, or did you bring them in to serve those functions?
We brought in our business intelligence to serve those functions, and we just got really lucky in hiring the people we got because they are really, really good at what they do. So yeah, we've been really fortunate in that arena.
But then it sounds as if your ability to extract data from your system and your ability to create your own kind of data governance and data definition models was really critical.
That and interoperability. Don't get a system that doesn't play well with other systems. I think, you know, the days of closed EHR systems are probably short-lived because of the need to share data. You have to be able to share data.
Yeah. Someone asked if you have community health workers as a part of your program.
We do not have, we have community relations people. We don't have community health workers. We have massive numbers of case managers who serve sort of multiple functions in terms of coordinating care, because they coordinate care both on the medical side and on the physical, on the behavioral health side. And that position actually is one of the positions that has sort of evolved over time to help to accommodate the need to have integrated care. So we've been fortunate in that respect. And then we have something called an integrated health navigator that we use for our high cost, high need folks that have more training, usually on the medical side of the house.
And are those people going into the community?
Yeah.
To people's homes?
We have a lot of people that go into the community.
And do you use any peers? Do you have peer specialists?
We have a lot of people who work for us who get services in the system. Their job title is not peer.
Mm-hmm.
Their job title could be case manager, clinician, ops coordinator.
So, but you don't specifically.
I don't know if people know this or not, but in Arizona, we have a very robust peer and family community that has been in existence for at least 20 years, and it's very well established. And so the days of like hiring a whole bunch of people with lived experience and saying, okay, you're all peers, we still have those positions, but they've started to evolve because people now know that the medicine is better, we have better therapeutic interventions, and we know that people can learn to manage their illness. It's not
Sure.
different than learning to manage your diabetes or your hypertension or your weight or, you know.
Yeah.
So,
Someone asked if you could share the qualifications for case manager in your organization.
yeah, typically we like to hire people who with a bachelor's degree in like social work, psychology, some type of behavioral health entity. We also will take somebody with a associate's degree with a couple of years experience. So.
And I think we only have time for one more question. Just your top tip. I think you've already given us the communication tip, but you're kind of, I'm sorry, there's a follow-up. Do you use nurses, and do you use nurses with Bsns as case managers?
Yeah, no. We do not use nurses to case manage. We use nurses to do nursing assessments and work in the clinics and provide nursing services. All of our clinics have nurses. You can't really do this without them.
Yeah, absolutely.
And then our contracts require a certain level of nursing in order to do the work. So it's hard to hire Bsns who are going to want to go out and chase people through the homeless, the homeless encampment.
Right.
Not really up for that most of the time.
We are pretty much out of time. I think there's one more slide. Just want to make sure that folks know about NextGen Healthcare, nextgen.com. There's a lot of information about their behavioral health suite of functionality. And then Integrated Care Online, which is a sub-community that's sponsored by NextGen and organized by Open Minds, has a ton of information on integrating care, whole person care, and we invite you to visit that. And then our final slide is, I think, all of our terms and conditions that the legal team wants to make sure get noted. And on that note, we are out of time, but thank you so much, Mary Jo, and thank you, Graham. This was a really fun deep dive into the pitfalls of trying to do integrated care. I appreciate your openness in talking about this stuff. And thank you, everybody who joined us for this webinar. As we mentioned earlier, we will be sending out links to the recording, and you will be able to access the slides, etc. So thank you all so much. Have a wonderful rest of your day.
Thank you.
Okay. Thank you.